Following the procedure and 12 months prior, the patient noted minimal improvement of vision, prompting consult at our OPD. So 12 months prior at our OPD, patient was noted with a visual acuity of 20/50 on the right eye, 2100 on the left, with no improvement on pinhole. On dilated fundus exam, patient was noted with diffuse dot and blot hemorrhages with neovascularization and minimal vitreous hemorrhage on both eyes. Patient was also noted with laser marks on all quadrants of the mid-periphery and periphery. Patient was thus managed as a case of PDR high risk for both eyes, cataracts both eyes, status post PRP for both eyes. Patient was thus referred to retina service, and a second session of PRP was done for both eyes. On initial follow-up following this PRP, there was noted resolution of the vitreous hemorrhage and decreased neovascularization. No improvement of VA was noted yet at the time, and patient was advised for strict follow-up with endocrinology service for control of blood sugar and for follow-up with their service for monitoring of the retina. Patient was, however, lost to follow-up as they were allegedly satisfied with the results of the PRP. Up until 1 month prior, when patient noted recurrence of the blurring of vision, again more prominent on the left, described as cloudy, and this was now associated with floaters on the left, prompting consult. So for the patient's ocular history, patient does not have any spectacle correction and denies his prior ocular trauma. He has, however, undergone PRP as mentioned for 2 sessions in 2024, once in another institution and once here. Patient also had initial poor health-seeking behavior, only being diagnosed with hypertension and type 2 DM after experiencing a non-healing wound requiring subsequent amputation in 2022. Since then, however, patient has maintained regular follow-up with medicine service, with good control of his blood pressure in the 110s for the systolic blood pressure, as well as good control of blood sugar with 6.4 to 6.9% for his HbA1c. For the patient's family history, he admits that his family does not seek regular consult, so he denies his family history of type 2 DM and hypertension, but believes that it may be undiagnosed if ever. Patient also has impaired ambulation, having been amputated before on the left, however, with prosthesis. Patient is also otherwise independent on other activities of daily living. Patient works as a hairstylist with no history of smoking or alcoholic beverage use. Now, on examination, patient was noted with a visual acuity of 20/80 on the right eye, improving to 20/50. This is in comparison to the year prior, where patient had a visual acuity of 20/50 prior to being lost to follow-up. On the left, patient had a visual acuity of 20/200 with no improvement on pinhole. This is in comparison to last year, where patient had a visual acuity of 20/100. Refraction was also done with noted mixed astigmatism. For the physical examination of the anterior segment, it's generally unremarkable. However, there was noted cataracts on both lenses, graded NO2 and C2 for both eyes. On gonioscopy, angles were open and pressures were normal at 15 for both eyes. However, Amster was done with noted metamorphopsia superiorly on the left eye, as you would see in this photo. So dilated fundus exam was done on the patient. So on the right eye, we would see through clear media a yellow-orange disc with distinct disc borders, a cup-to-disc ratio of about 0.7. We noted inferior rim thinning, peripapillary atrophy on this eye. There were also areas of neovascularization and intraretinal microvascular abnormalities in the superior and nasal mid-periphery. Dot and blot hemorrhages were also seen in all quadrants of the mid-periphery and periphery, as well as pre-retinal hemorrhages in the inferior nasal periphery. Hyperpigmented and hypopigmented laser marks are also seen in all quadrants of the periphery with an intact foveal reflex. For the left eye, we have a very hazy media, secondary to a vitreous hemorrhage. However, we note a yellow-orange disc with distinct disc borders, a cup-to-disc ratio of about 0.6. In this image, the vessels cannot be fully assessed, and again, a media opacity, likely the vitreous hemorrhage, obscures most of the superior temporal and inferior mid-periphery and periphery. Blot hemorrhages were, however, seen in the superior and inferior to the disc, and in all quadrants of the mid-periphery. There was also noted, here in the next photo, areas of neovascularization in the superior mid-periphery. Similar to the other eye, there were also hyperpigmented laser marks seen in all quadrants of the periphery. So for the salient features of this case, we have a 61-year-old male, known hypertensive and diabetic with a history of PRP, but this patient was subsequently lost to follow-up. This patient now came in due to a chief complaint of gradual blurring of vision, described as cloudiness for both eyes, more prominent on the left, with noted metamorphopsis on the left eye, a low-grade cataract graded NO2 and C2, blood and blood hemorrhages, neovascularizations seen on both eyes in the dilated fundus exam, as well as preretinal hemorrhage on the right and vitreous hemorrhage on the left. This gives us a primary impression of mixed astigmatism for both eyes, cataracts for both eyes, vitreous hemorrhage on the left, glaucoma suspect for both eyes, proliferative diabetic retinopathy, high risk for both eyes, status post PRP. Given these findings, we also have a few differentials. First of all, your hypertensive retinopathy. So we consider this considering the patient's history of hypertension, as well as decreased visual acuity and the presence of retinal hemorrhages. However, the patient does not have signs of malignant hypertension on presentation. There doesn't seem to be vessel attenuation or tortuosity, nor arteriovenous crossing signs. There are also no copper or silver wiring, and the patient also has distinct disc margins on fundoscopy. We could also consider central retinal vein occlusion, again, due to the decreased visual acuity, the presence of the risk factors, considering the patient's comorbidities, as well as the presence of diffuse dot and blot hemorrhages. This, however, is less likely because in our patient, the symptoms were gradual in onset compared to CRVO. There is no particular timing to the patient's symptoms, and again, we note no vessel tortuosity. So for this patient, an OCT macula was done. Shown here is for the right eye, and we see here with good signal strength, a blended foveal contour with well-delineated retinal layers. There's a thin hyperreflective band overlying the retina with associated surface wrinkling. And we also note an area of hyperreflective tissue protruding from the posterior hyaloid into the vitreous. In this cut of the OCT macula, we also see hyperreflective cysts, however, with no subretinal fluid. We also note an intact outer retinal band. In the thickness map, we also see generalized perifoveal thickening with the central subfield thickness above the 99th percentile. For the left eye, the scan was done with very poor signal strength. This was 1/10. So the retinal structures and layers couldn't be fully assessed. The thickness map does show thinning of the superior and nasal paraphobia and thickening of the temporal paraphobia, with a central subfield thickness below the first percentile. An OCT optic nerve head was also done, considering the inferior rim thinning seen on the fundus exam. And here we see with good scan quality for the right eye, an average RNFL thickness below normal limits with poor symmetry. Cup to disc ratio is about 0.77, with noted superior and inferior rim thinning of your RNFL. For the left eye, there was poor scan quality and large signal dropout. VFT was also done for this patient, 24-2 CETA standard, and we note with acceptable reliability parameters an incomplete dense double arc width scotoma. It's worth noting, however, that this patient again is post-PRP, so the visual field defects we see here might be confounded by that prior procedure. So following these, we arrive at a diagnosis of mixed astigmatism again, cataracts for both eyes, vitreous hemorrhage on the left, POWAG for both eyes, proliferative DR again, high risk for both eyes, status post PRP. So focusing on our case today, diabetic retinopathy. So this disease represents a microvascular and organ damage occurring from the long-term effects of hyperglycemia and DM. So this is actually the most common microvascular complication of DM, and symptoms can range from a non-proliferative disease with asymptomatic conditions to something that's more proliferative. And with progression of this disease, we could also note macular edema. So DM retinopathy is the leading cause of visual loss among persons aged 25 to 74, with the AAO noting a global burden of DM for almost 400 million persons globally. Of these, about 100 million are affected by DM retinopathy. Of note, about 3 of 4 cases of type 1 DM have some form of diabetic retinopathy, And about 1/4 of cases of type 2 DM have some form of diabetic retinopathy. Now, for the pathophysiology, DM retinopathy is primarily driven by chronic hyperglycemia as the pathogenic agent. So this chronic hyperglycemia induces the activation of alternative pathways of glucose metabolism, such as your polyol pathway, the production of your AGEs, as well as the activation of your protein kinase C, which could activate thereafter your cytokines and growth factors. This would induce vascular endothelial dysfunction, which could increase your vascular permeability, produce microvascular occlusions, which could thereon lead to ischemia and neovascularization of your retina. Now, characteristic findings you might see in your diabetic retinopathy. First of all, this could start as a asymptomatic disease, later progressing to vision-threatening disease, that is, especially without timely and appropriate intervention. Now, as an asymptomatic stage, the earliest fundus findings we might have, if any, are microaneurysms and intraretinal hemorrhages. Decreased visual acuity might be noted due to the increased vascular permeability, producing retinal thickening or maybe even lipid deposits seen as your exudates. As the retinopathy progresses, you could expect constriction of your retinal vessels, impairing your perfusion of the retina, causing ischemia. At this stage, we might expect venous dilation, venous beading, as well as extensive hemorrhages. And PDR, proliferative diabetic retinopathy, is an advanced stage where we see neovascularization occurring due to widespread ischemia. So these new vessels increase the risk for vitreous hemorrhage, which may be seen as floaters, like in our patient. And this neovascularization could also form fibrous scaffolds that can contract, causing traction and even retinal detachment. So as you would see in this picture, this is our staging for diabetic retinopathy. And you would note that these corroborate with the characteristic findings of DM, ranging again from its asymptomatic stage onto its more advanced stages. So again, with microaneurysms being an indicator of mild non-proliferative disease and the subsequent presence of increasing hemorrhages, venous changes as signs of progression, and even the presence of neovascularization as indicators of advanced proliferative disease. Shown here are various risk factors for your diabetic retinopathy. For our patient, it involves being in the male sex, poor glycemic control, as well as poor blood pressure control, dyslipidemia. Other risk factors we might note in other patients might be the presence of nephropathy or even obesity. So generally, these risk factors revolve around your chronic hyperglycemia as well as insulin resistance. Now, for the management of this patient, integral to the management of DM retinopathy is really the management of the DM itself. So thus, this should involve control of the blood sugar and other comorbidities. It becomes integral for our patient to control their BP, lipid profile, and blood glucose to help halt the progression of the DM retinopathy. Considering the vitreous hemorrhage seen on this patient's left eye, we advise them to maintain high backrest to allow for the hemorrhage to settle. The patient was moreover referred to our retina service and started on intravitreal injections with bevacizumab. This is with the end goal of retarding current neovascularization and controlling the macular thickening. Again, we noted cystic spaces on the patient's OCT macula of the right eye. Now, with these two interventions, the high backrest and the intravitreal injections, we'll monitor the patient for either the persistence or resolution of the vitreous hemorrhage, which also prevents us a clear view of the retina on the left eye for any subsequent intervention, such as PRP. So based on the diabetic retinopathy study, PRP does have the benefit of reducing the risk for severe vision loss by at least 50% in treated eyes, with the greatest benefit in patients with high-risk PDR. Based on your BRC or protocol I as well, anti-VEGF therapy combined with either prompt or deferred laser treatment does have better outcomes compared to just laser treatment alone. And it's particularly important to aim for PRP after the IVI. Following an BRS, the PRP can reduce risk of severe visual loss and can induce regression of your retinal neovascularization. If, however, we see signs of retinal detachment or macular traction at any point of treating this patient, this would warrant reassessment and consideration for surgical intervention, such as vitrectomy. We should also consider PPV if the patient's condition remains refractory to both PRP and anti-VEGF treatments. Considering the condition of the patient's optic nerve as well, the patient was referred to glaucoma service and started on brimonidine eye drops. Finally, close follow-up must be emphasized for this patient to initiate or guide treatment, with responding to either progression or improvement of the patient's condition, altering our management according to our patient's status, more or less. Now, for the outcome criteria for this patient, starting with both eyes, it's the control of current neovascularization and prevention of further progression. Considering the status of the optic nerve based on fundoscopy and OCT, a target IOP of less than 18 millimeters mercury with 30% reduction from baseline may be considered. For the right eye, we aim to prevent progression of macular thickening or worsening of vision. Based on the DRC, our retina network anti-VEGF treatment algorithm, this would entail no progression of central subfield thickness by 10% or more, or worsening of the VA by 5 letters or more. For the left eye, we aim to produce a clear view of the retina first by means of, again, positioning and controlling risk factors for the hemorrhage to allow for proper baseline imaging and intervention, such as subsequent PRP. All these interventions, however, must be done with the end goal of optimizing control of other comorbidities, particularly aiming for an HbA1c of 7% or lower for the patient's diabetes, as well as intensive management of the patient's hypertension and serum lipids. So moving on, Barbs will be discussing a journal related to this case.
Okay. Good afternoon. Before you discuss that, Barbs, do we have any questions for Rich? Can you go back to your PE lab? I just wanted to point out some things that you... First, congratulations, that's a good presentation, no? But if you look at your lab there, if your PE, what doesn't add up here? Anything that would make you suspect that I need to do the exam again, I need to check it? Barbs, go. Any other resident? Okay. Well, just be very careful. On your right eye, your 2080 correctable to 2050, no? BCVA mo. And yet, you're J1. No? So, it sort of doesn't add up. No? How can you achieve J1 on near, but 2050 ka lang on distance? So, be careful with this one. You might have to recheck if this was done by an intern or this was not done by yourself. If it was done by another resident. No? You're presenting this, so you're ultimately in charge of the data. Okay? So this is a little bit iffy. No? So Jan? Sorry.
Yeah, I have another question. Can I be heard? I'm outside.
Yeah.
Yes.
Is there a role for cataract surgery? And if ever there is, when is the best time?
Go ahead, Rich, Barbs.
Considering the patient's high risk diabetic retinopathy, it's more integral. I believe it's more integral to focus on controlling the neovascularizations the patient's facing, preventing progression of their retinal findings before we could consider working on the cataract diagnosis. We want to protect the retina and basically the patient's nerve as well, considering the glaucoma diagnosis. Once that's stabilized, I believe that's when we could also start fixing the cataract.
You try to look what is contributing what to the vision, no, to the visual acuity. In this case, I agree. It might be more prudent to fix your diabetic retinopathy first. No? Also because your cataract is what level? NO2 lang yata, di ba?
NO2 and C2.
Oh, NO2 and so you might want to look into that, no? Kasi kung NO2 lang siya, you also have to wonder what visual gains you will get from cataract surgery. Eventually you will, no? But you have to determine what's causing your 20/50 on the right eye, on the good eye, no? If you look at your OCT on the right eye, sige. Look at your OCT on the right eye. Meron kang what? Kulang ka ng diagnosis.
Diabetic macular edema.
No. Well, no. Epiretinal membrane.
Epiretinal membrane.
So, kulang ka ng diagnosis sa epiretinal membrane. The one that's causing the poor vision on the right eye is most likely an epiretinal membrane, no? So you do have some cystic changes there, as you pointed out, but I don't think that's the one that's causing the poor vision. I think it's more your epiretinal membrane. Okay? So go back. Yung mas maganda, the other one. Yan. You see that the retinal surface is wrinkled, no? It's thrown into folds by that either an epiretinal membrane or a posterior hyaloid. And if you look to the left of that big image, it seems like there's some extraretinal fibrovascular growth there, no? So you have to be, when you're determining what needs to be done, no, or how to manage the patient, you have to look at all the conditions and what it might be contributing to your visual decline. Okay. Now, for the left, can you go back to your PE lang on the left?
Cross for us.
Back pa. I am very, ayan, yung sa, ano mo, sa Amsler mo. Any questions on the Amsler?
Po ba yun?
Any concerns about the Amsler? Sino na dyan? Steven.
Sa may simple,
Steven?
Yes, Doc.
Anong concern mo dito sa Amsler mo? On the left. Anyone? Jolo, Oli, Trisha.
No. Kanina kasi it was mentioned na patient was J1. So probably it doesn't coincide din on the
On
right.
the right, but on the left. On the left. Left mo yung may finding eh.
Yeah, J12 yung left, Doc. So it also doesn't
unreliable.
add up, Doc.
Yeah. So your vision is quite poor, no? So medyo mahirap to determine metamorphopsia with very poor vision at 2200 unless the 2200 is really being caused by the metamorphopsia. No, in this case, the 2200 is most likely caused by the media opacity. So medyo I'm not sure how much credence you can give to the Amsler grid in this case, no? Kasi kung poor vision, I doubt kung makakakuha kang ganito ka-detailed na Amsler. But again, the point is, I'm not questioning your findings. The point is, if you see something like this, you have to do a double take, no? Check mo ulit and tingnan mo kung talagang may ganitong findings on Amsler. Okay? Do we have any other comments from the retina service? Sige. From REM? PO?
Actually, my comment is with regards to the glaucoma, Doc.
Sige nga, o yung glaucoma.
The nerve, can you look at the nerve? Yeah. What's your interpretation with this one, Rich? Yung pinaka-importante pa yung hindi mo nilagay dito eh. What did you crop out? Yung una mong tinitingnan.
The reliability po.
Reliability in this test. What do you think is the reliability of this test?
rather poor po, Doc, considering that the patient does have hemorrhage and media opacity po, Doc.
Yeah, and look at the RNFL6 circular tomography, yung nasa pinakababa na left part. It's crooked. It's not identifying the right retinal layers. The left eye throw everything out na kasi that's totally inaccurate, no? The right eye, I could agree that there's thinning on the superior and inferior, but we don't know if that is from a glaucoma or from a retinal pathology causing thinning ng RNFL. So we correlate it with the photo. Can you go to the photo? But in the photo, we can appreciate naman that there's really thinning in the rim thinning. So I agree naman that for whatever it's worth, whether the visual field deterioration or visual deterioration is from cataract, from glaucoma, or from retina, at least try to lower down the pressure with the least medication, the cheapest medication available, and with the better compliance. So aside from, are you going, and you're targeting 30%. So what could be a better option?
More lenient IOP target po, Doc. A more lenient IOP target. So
Kasi
siguro
you're giving, what are you giving right now?
Brimonidine.
Brimonidine. Your angles are open.
Yes po, Doc.
You don't have any other secondary causes, 'di ba? For now, for now. So we're assuming it's a primary open angle glaucoma coinciding with proliferative diabetic retinopathy, but our pressures are, our baseline pressures are normal, 'di ba? So parang lumalabas na NTG pa siya. Tama? So you can give what? Aside from brimonidine. Kasi brimonidine, your application is 3 times a day. It has some side effects as well. It can work for both open and closed angles, 'di ba? Pero siguro if you want higher pressure lowering, if your IOP is starting from a high point, then you can go for prostaglandin if there's no contraindication. If you just want to lower it down a little bit more just for pressure lowering, especially with this kind of nerve, then probably timolol can also be a good option kasi it's cheaper than brimonidine. Compliance is better with once a day in the morning or maximum of 2 times a day in the morning and at night. Yung left eye, definitely, we cannot diagnose it properly. No? So, basis na lang natin is the right. Ayun lang.
Thank you, Doc.
So, Rem, is
Yes,
there
Doc.
basis to change the diagnosis to an NTG?
Ah, Rich, ano dapat ang gawin mo to answer the question of Dr. Valero?
Yeah, this is good.
Ano dapat ang gawin mo to differentiate NTG and primary open angle
So
glaucoma?
we could take the urinals po, Doc, just to see whether the patient has pressure spikes at any time, any other time of the day, or whether they really have normal pressures all throughout.
Yeah, so do the urinals para lang to make sure that there's no really peaks in the pressure. If that's the case kasi na may peaks ka, then that's POWAG. But if you are below 20, then that's probably NTG.
Okay, so looked very simple but actually marami kang kailangan gawin dito, no? One is to determine whether this is NTG or POWAG because your management and your follow-up will change, no? Depending on what your diagnosis is. And you will also need to determine what the next line of treatment will be for the right eye and the left eye. So I agree with your assessment, and your plan for now for the diabetic retinopathy is to for the PDR in vitreous hemorrhage on the left is to inject muna, no? You don't have any clear overt signs of a tractional detachment. It looks like it's just really diffuse hemorrhage. So you can probably just give the injection first. Hopefully, you decrease the VEGF load and you stop the neovascularization from progressing and you let the blood settle on its own. And once it has settled, you can probably do a more permanent treatment of PRP, no, considering that the patient has very poor follow-up as well, no. For the right, what did you want to do on the right, Rich?
So for the right, doc, we'll reevaluate. We're gonna reevaluate the patient after the uh, intravitreal injection, see if there's any clearing up of the media. If there is, we
For
could
the right,
consider PRP.
for the right.
Oh, for the right, doc. Yeah. Similarly, doc, we also want to target PRP, considering again the retinal thickening we see on our patient as well as the macular edema. So the combined
Okay.
PRP.
Sige, ano muna, on the right eye, you don't have diabetic macular edema. I don't think you have diabetic macular edema. You actually have um, epiretinal membrane and PDR. No, you still have a persistent PDR, an active PDR at this point, as you've correctly pointed out. There are still neovascular, there's still NVEs, no, and a pre-retinal hemorrhage. So na, hindi pa rin siya quiescent. So I would probably just stick with the PRP on this eye, stabilize the eye, so that it becomes quiescent and your neovascular activity decreases. And then maybe manage the epiretinal membrane if you so choose, no? So I don't think this is a case of macular edema that is vascular or diabetic in nature. There's probably some swelling because you have your epiretinal membrane. Okay? So yun yung ano. I would probably just do a PRP on the right, additional PRP on the right. Although you are correct, you can give anti-VEGF for the NV, but because of the poor compliance of this patient, I would probably go with PRP. Lloyd, nandiyan ba si Lloyd? Baka may comment si Lloyd. Albert, sino pa nandiyan? Joel,
Hi, Doc. Good
Gary.
afternoon.
Yeah.
Just to add lang rin, anyway, it was a good presentation, Rich. But maybe next time you could add peripheral shots of the fundus of the patient so we could see the status of the PRP as well. If the patient finished the complete session of PRP or if there's space to add additional laser. And especially we have the equipment naman to get peripheral shots.
Thank you, doc.
That's
We'll
all.
take note of that.
Can you show the fundus photo lang of the right? Rich, can you show the fundus photo on the right? Yeah.
Here po, doc.
So what can you comment on the laser here? Is Trisha there? Trisha?
Parang we can still fill in.
Ito, mas mature. Ito
So you
naman,
have
all the
skip
pictures sa
lesions, skip
pastel.
areas, no? The way you describe it
Yeah.
is you have a lot of skip areas and a lot of parang what do you call that? Malayo yung spacing niya. So in this case, you can still add laser. Okay. Usually tinatanong sa board yan kung may skip areas, no? Kung the laser spots are too far apart, no? The standard placement would be one spot size apart all over the mid to peripheral retina. Okay. All right.
Yeah.
Any other comments? Okay, there was a question from Dr. Matanggihan now about laser trabeculoplasty in POAG with diabetic retinopathy. Rem said, SLT can also be an option if you're sure na walang NV sa angles. Both for POAG and NTG, doing SLT is a good option instead of placing the patient on medications. So that is also an option, no, especially considering that the patient has very poor follow-up habits, no? So you might want to do something a little bit more definitive. Kung, as you've mentioned earlier, poor health-seeking behavior, you might want to do something a little bit more permanent for the patient. Okay? Sige. Do you have any other questions or comments? We can have Barb present her journal.
Hi, good afternoon, everyone. So today we'll just discuss two short journals. So for this patient, one of our main problem was the patient's loss to follow up. So we have these two journals. They studied patients with diabetic retinopathy who were also lost to follow up. These studies were conducted in Canada and the US. So for the first study, we'll discuss. It is a multi-center retrospective cohort study conducted in Canada, analyzing the 10-year medical record of almost 3,000 patients being treated for PDR or DME. Eligible patients that were included, they were at least 18 years of age. They received at least one session of PRP or IVI of anti-VEGF, had at least 1 year of follow-up with their retina specialist after the initial consultation. Patients were excluded naman if they did not require treatment during the follow-up period or if they were referred to another specialist for further management. Treatment burden categorization included IBI, which was the standard of treatment for DME and adjunctive or primary therapy for PDR. It also included PRP, which is the long-standing treatment for PDR to prevent severe complications. Burden was classified as low if the patient received less than 6 anti-VEGF or less than 4 PRP sessions. The primary outcome of the study was the loss to follow-up rate, defined as the absence of any ophthalmic visit or intervention for 1 year after a patient's last visit with their retina specialist. Patients were further classified as temporarily lost to follow-up if they returned after 1 year of gap, or permanently if they didn't return at all. So the study included almost 3,000 patients with diabetic retinopathy receiving anti-VEGF or PRP with a mean age of 71 years of age, and half of them were male, with an average follow-up of 61 months. So of the patients, 507 or 17% were lost to follow-up after the 1 year period, with 54.4% as temporarily lost to follow-up, or and 45.6% didn't return. So from this study, older patients aged above 75 had lower odds of being lost to follow-up compared to those under 65 years of age. Male patients had higher loss to follow-up rates compared to the female counterparts, and patients who lived a greater distance from the clinic showed increased risk. Patients with a baseline vision or worse than baseline vision of 2100 were less likely to be lost to follow-up, and having diabetic macular edema at baseline was likewise associated with lower odds of being lost to follow-up. While PDR, NDI, and tractional retinal detachment showed no significant association. And then patients with more than or equal to 6 visits or with a high anti-VEGF burden in the first year was linked to lower odds of being lost to follow-up, and patients receiving PRP in their initial treatment were more likely to be lost to follow-up than those receiving anti-VEGF. So Patients who are temporarily lost to follow up, usually they were older patients, had lower odds of being temporarily lost to follow up compared same as the findings as earlier. So those who had more than 6 visits in the first year was associated with lower temporarily lost to follow up, and patients receiving PRP in their first visit also had them more likely to be temporarily lost to follow up than those receiving anti-VEGF. And high PRP burden in the first year also increased the temporary loss to follow up risk. While those with baseline diabetic macular edema was also associated with lower odds of permanent loss to follow up, high anti-VEGF burden in the first year significantly reduced the permanent loss to follow up. And then, yeah. So to summarize this study, the potential explanations given. So those who had received PRP treatment may lead to higher loss to follow-up rates because it provides a longer lasting effect than the anti-VEGF, possibly making the patients feel like further follow-up is unnecessary. Anti-VEGF require frequent follow-up, which improves adherence. However, adherence is crucial for visual outcomes, as irregular injections may reduce the treatment efficacy. Patients with more severe disease, those with worse BCVA or diabetic macular edema, may likely require more frequent treatments and therefore more engaged in the follow-up care. And patients who are living farther away had significantly higher loss to follow-up rates, highlighting the geographic barriers to care. And those patients who are younger than 65 years old had higher loss to follow-up rates, possibly due to employment, childcare responsibilities, and financial constraints. So limitations of this study included that the patients may have continued the care elsewhere. Findings may not be generalizable in rural areas as the study was focused on the city. There was also limited EMR data. It didn't include the chronic comorbidities of the patients, HbA1c levels, and concomitant medications. And reasons for loss to follow up were not really captured, limiting the insight to the patient's adherence to the follow up. So to improve, patients may be given automated reminders such as text, calls, or app notifications. It could also be given in their preferred language, or you can also give them educational materials that's culturally tailored to improve their understanding. Although this next one, it is more harder to do. You could address the geographic barriers by giving them transportation assistance programs, or you could align their schedule with another patient as to have them do group transport. So you could also communicate with the patient's primary care providers as to reinforce the importance of the follow-up. Integrated EMRs across specialties could also provide better tracking of the patients at risk, and nurses or other healthcare providers could make calls or communicate with the patients as they have similar cultural backgrounds. So for the next study, we'll be discussing. It is a retrospective cohort study utilizing data from the IRIS registry. It is the largest ophthalmologic data registry in the US. It includes data from almost 3,000 ophthalmic practices, 15,000 ophthalmologists, and around 79.4 million patients as of April 2023. So eligible patients that were included are those with PDR between 2013 to 2015. They were identified using ICD-9 and ICD-10 codes. They were excluded if they have a history of exudative AMD, RVO, myopic CNVM, or idiopathic CNVM. Treatment for anti-VEGF or PRP was identified using the CPT codes, and only treated patients were included in the study. So data were analyzed up to December 2018, ensuring that all patients had received anti-VEGF or PRP or both in their initial after their initial diagnosis. So between 2013 to 2018, a total of 73,595 eyes from 56,000 patients were diagnosed with PDR were treated. Of these, 11.7% were lost to follow-up, while 88.3% had follow-up within 12 months of their last treatment. Additionally, 31% of the lost to follow-up patients returned for follow-up within 4 years. And the baseline demographic clinical characteristics are detailed in Table 1, this table. So several factors to loss to follow-up for patients with diabetic retinopathy. Higher odds were observed in patients under 55. Unilateral involvement also had higher loss to follow-up. Worse baseline VA of 2,200. Those with type 2 diabetes compared to those with type 1 diabetes. And the treatment type also influenced with lower odds of patients receiving both anti-VEGF and PRP being lost to follow-up. So among patients lost to follow-up after treatment, the average time for first treatment from the last visit was 413 days, significantly shorter than the 1,300 days of those who were not lost to follow-up. Treatment characteristics, patients lost to follow-up receive slightly higher anti-VEGF burden of 4.6 compared to 3.9 in those not lost to follow-up, and those PRP treatment was similar in both groups. So complications, those who were lost to follow-up patients had lower rates of complications compared to those who were not lost to follow-up. So this study just highlights that those of African American descent, Hispanic, Native American, unilateral involvement, BCVA worse than 20/40, and those with type 2 diabetes had higher risk factors, while those of older age or who underwent combination treatment had lower loss to follow-up risk factors. So the strength of the study was that it had a large sample size and it could track patients across the multiple practices. However, there was a limitation of possible data errors, lack of detailed clinical data, and it could also be due to the pandemic's impact. So based on these both studies, it was, just to summarize those two studies. So the first study found that those who presented with higher risk factors are males, those who are living farther away from the treatment site, those who initially received PRP, who had the better base BCVA, and those who had fewer follow-up visits and lower IVI burden in the first year. While in the second study, it showed that those with unilateral involvement and poor BCVA had higher risk. So just to conclude,
Barbs, mali go back. The BCVA is better than 20/40. Doon ka nalo-lost to follow-up. So, good VA.
Yes, Doc. Sorry, Doc.
O mali
Baliktad pala
ang...
siya. Both
Oh.
studies.
So, it should be worse than 2040 or better than 2040?
Bali, the first study, they found that those with better BCVA, higher risk niya. Pero dun sa second study,
Poorer.
poorer yung lost to follow up.
Be careful with your ano lang.
Yes, Doc.
Kasi this means better than 2040.
Opo.
Okay.
So just to conclude, we should identify those who are at-risk populations for targeted interventions. We should also increase the accessibility of patient education and come up with follow-up strategies such as reminders in their preferred language and possibly provide transport assistance. And you could also communicate with their primary care providers to reinforce the importance of the follow-up.
So going back to this case, based on the guidelines by the VRSP, they recommend that high-risk PDR patients follow up between 3 to 4 months, and those with clinically significant macular edema follow up monthly. So it's important to emphasize to these patients that diabetic retinopathy really requires lifelong care. It's important to be examined regularly if there's any form of worsening, or even if patients are improving, or even if they are asymptomatic. It's really integral to see patients, to see any changes, any progression early on, as early treatment does decrease risk of vision loss. So that basically concludes our presentation. These are our references. So thank you for listening, doctors.
All right. Can you just go back to your second to the last slide, Barbs? The last, yung comparing the two studies. Okay. So, from a public health perspective, no, you have to understand that these two countries have different healthcare systems, no. In Canada, it's socialized, so everyone has access to healthcare. Whereas in the States, if you look at this demographic, no, African American, Hispanic, Native American, Native Hawaiian, Pacific Islanders, these ethnicities are traditionally the ones with lesser access to healthcare, to private healthcare. So, access to healthcare also plays a big role. No, in Canada, all things being equal, you're male, malayo ka sa clinic, that becomes a factor. No, but a big factor in those that don't have socialized healthcare, just like the Philippines and the US, access to healthcare is also a big problem. So here, you also have to put into consideration na not just because they're male, malayo sa clinic, initial baseline, better baseline VA or naka-PRP, it's also kung they can afford healthcare. No? So it's very important for us to remind them that, you know, they're in the OPD naman, so mababa naman yung cost ng healthcare doon para hindi sila nakaka-lost to follow-up. Okay? So any other comments from the other consultant? Okay. So if there are no other comments, no, thank you very much to Rich and Barbs. Good job. No, very interesting journals. No, I think it's very important for us to know what factors come in or are in play when we're asking patients to follow up. No, so again, bear that in mind. No, so when you're advising your patient, alam nyo kung sino yung medyo mas konting explanation at mas extra encouragement to follow up, no? Of course, this is North American data, but you can glean some information from this, no? Okay, some few announcements, no? Regarding the IOL, the anong IOL yung available?
iCrill, Doc. iCrill.
iCrill IOLs are now available for use through the hospital, no? And good news for those using HMOs, what the OR has decided is that they will first kung may sobra dun sa PhilHealth, no, unang babayaran yung IOL ng PhilHealth, no? And then the rest will be taken care of by the HMO. Okay? So basically pag HMO, wala nang babayaran yung pasyente, I think, no? So we're just waiting for the at least for the iCrill IOL, no? So we're just waiting for the memorandum from OR to give us the full details of how the process will go, no? For now, again, we only have iCrill. We will soon have, these are monofocals. We will soon have Cure, which is a multifocal IOL. And eventually, depending on the demand or the parang requests from the consultant staff, no, we will see what else we can put in. We are still trying to figure out a way for the mechanics of this so that hindi tayo mahirapan mag-order, no? So we will come up with the process flow for everyone's information. Okay, so congratulations everyone for a very successful JCI, no, accreditation. Special congratulations to the ones I mentioned before, you know, for all the hard work, no, for our documentation, for our corneal transplant program, for the laser and optical radiation safety, no. Even for the OR, I think they checked on a few opta charts, and I think we did okay. Just a few announcements going forward. We'll be releasing it soon, but that would include for the eye center, you would probably need to do your consent already in the clinic, just like in the OR, no? Mag-consent na kayo sa clinic before you send the patient up, because technically you should be the one doing the consent and not the nurses, no? These are for your procedures like laser or injections, no? Two, we will be stricter with the engagement of our consultants with the hospital. They medyo nasilip yung engagement ng mga consultants natin. Some of us don't even have procedures or referrals to the eye centers for the entire 3 years, no? So we will be stricter about that. I think the recommendation is you have at least 10 engagements a year. So 10 referrals to the eye center kahit for diagnostic is considered already an engagement. So kahit hindi ka mag-opera, basta nakapag-refer ka sa eye center for a procedure, for a biometry, for a visual field, no? So that will be considered an engagement. Your renewal as a consultant, as either visiting, associate visiting, or associate or active consultant will depend also on your engagement in the hospital. Okay, so announcements now for the eye center. The IDRA, the dry eye diagnostic, is already available. Now we will be sending out the memo on how much it will cost, no? And your BlephEx, and the micro exfoliation is already available as well. And also the UBM, no? So we already have consultants who will do the UBM for you. So please send in your request, and then your BlephEx, you can already do that, and your IDRA, the dry eye diagnostic suite, is already available. So you will be getting a memo on that soon. So thank you very much. Any other questions, Jan?
Uh, 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 Regarding the informed consent, are we going
Yeah.
to have a template for that for each
Yes.
for every
So
procedure?
it's not per procedure, it's a general consent, no, that we use in the eye center. What happens kasi is that when the patient registers, dun lang piniprint yung consent. So tapos ang nagko-consent are the nurses, no? So what we will do now, we are still fixing this, is that we will be sending blank consent forms to the clinics, no? At least for the ones who are in the hospital, and then you will have to send up your consent form together with your request, no? Of course, pag hindi nagawa, aantayin kayo sa taas to consent the patient, no? So because technically nga it should be the doctors who are doing the consent. Remember, we don't have residents in the eye center, so the nurses are not technically allowed to do the consent form for our procedures, no? At least the interventional ones. I think they're allowed to do it for diagnostics, but not for the lasers and for the injections. So we will be sending out a memo on this one. We're just preparing everything. So don't worry, we'll keep everyone informed.
Thank
Okay?
you.
Thank you, everyone. Thank you very much, and we'll see you in the next conference. Thank you.
Thank you.
Thank you.